Ahmed was the guy who took me through my first navigated knee replacement about 10 years ago in UK. And now he's convincing us not to move forward. So I'm going to have a different view, and hopefully you will all be convinced by the end of my talk. So I work in Lahore, and if you want a PSI knee, it's not difficult. You get a CT scan, send that CT to the vendor, and you will get jigs back. You will put on those jigs and you do the cuts. Same implant which you're used to, you can do that. So you're not changing your technique, you're not doing anything new apart from getting a CT scan and some jigs in post, and they would need sterilization. This is inevitable, this is future, and I think in Pakistan this will be used more and more. So for PSI, you've got those plastic jigs, they are sterilized, you put them on, and you do the cuts. Those of us who have done it in UK, it's very easy. You are not changing anything virtually. So I would ask Amer, what would you do in this situation, because this is a common X-ray we see in our clinics at least.
Right. So this is a case with a proximal tibia malunion and arthritic knee. While I'm going to address this in my later talk this afternoon, but essentially I would go with long leg views to see the mechanical axis first. This is not a case I would decide based on standard knee X-rays. Now, there are studies which are showing that even with conventional implants, as long as you get the mechanical axis right, you can address them and ignore most of the extra-articular deformities. Now, in terms of patient-specific instruments, yes, you can plan something with a PSI, but I will prove in my following talk that these are the cases you can easily deal with conventional implants.
Okay, thank you for your answer. Please continue with your presentation.
So let's move on to the next case. So this again is a very regular case where there is a malunion of tibia and you've got a plate in. Again, these are nice cases for PSIs, and this can always be considered. So if we move forward, like in this situation, again, PSI, you just take 1 or 2 screws off, and we talked about cost. So you are offering this patient another surgery to remove this nail, massive surgery, take everything out, high risk of complication, and then you do a total knee replacement. Instead, why not just take the metalwork which is on the way, put that plastic jig on and do a PSI. And let's come to the evidence. So we had this nice talk about kinematic aligned knees. So this RCT showed that PSI is a very well adoption and can be used and is as good as mechanical aligned knee. And in certain areas, for example, blood loss and recovery, it's better. So in this paper, this is also an RCT where kinematically aligned PSI was compared with mechanical alignment and showed better outcomes. Ali Siddiqui, JBJS, so this one meta-analysis with systematic review favored as far as operating time and blood loss, it was favoring PSI. So you can even use PSI in straightforward cases, in standard primary. So why can't we use PSI in special cases? So let's come to the gender-specific TKR. I overheard Faisal Kamar yesterday in the workshop telling the trainees, do not overhang, I think he stressed about 3-4 times, and I heard it on the other table, do not overhang. But do we really need an evidence to prove to ourselves that we should not be overhanging our implants? So we know that females are not a smaller version of males, they have got a different anatomy. So they have got a less prominent anterior condyle, they have got an increased Q angle and a reduced mediolateral and anterior-posterior aspect ratio. So if you look at these two implants, their anterior flange is different, and obviously they have been designed for male versus female, and it's very difficult to prove unless you have got very, very large registry data. So in this paper, again in RCT, both range of motion and satisfaction was better, but not statistically significant. Again, a well-designed randomized trial published in the JBJS. And then when we come to the high flex design, it's important over here because our patients demand more flexion due to religious and cultural reasons. And I think this is a good option available to us and can be considered. Again, we are not changing any technique. We are not putting anything special. All we need to do is to select the right implant and the right patient, and that should be considered as well. So high flex knee, in my opinion, should be considered in younger patient with cultural and religious reason. And as I said, there's no change of technique required. So in my opinion, PSI, gender-specific and high flex knee are useful in selected patients. And I'm sure you would all agree with that.